Blood goes in and pee comes out. That's it. Oh, that's all you got. All right. See you guys next
Take
Friday.
the test.
And ultimately, what this really is just management of fluids and electrolytes independently of one another. All right. So the kidney is able to manage our fluid homeostasis, our solute homeostasis, and then we want to throw an acid-base homeostasis independently of one another through various different mechanisms, some of which we've already discussed, right? What did we talk about as far as hormones that have an effect on the kidney so far from the endocrine block? Huh? ADH, right? What does ADH do? Retains water, right? What does aldosterone do? Secretes potassium and retains water and sodium, right? Through two different channels within the renal tubules, right? What is a hormone that the kidneys make that creates the beginning of the RAS? Renin. There you go. Okay. So all of these things, and then the main difficulty here of all this nonsense that you see is tubular secretion and reabsorption of the solutes, and where along the tubules what is being reabsorbed, what's being secreted. All right. And we've already conceptually talked about this kind of stuff before. We talked about capillary, right? Capillary pressures that push stuff out of the capillaries into the interstitial fluid. Stuff that pushes stuff back into or pulls stuff back into. So when we get to like glomerular filtration, GFR, it's going to be a very, very similar concept that we've already discussed. All right, just different names for the pressure, of course, because we have to name things differently. Okay. So functions of the kidneys, you guys could come up with this. This is just basics, the very, very basics. What does it do? It regulates blood volume, fluid, right, through the mechanisms that we just talked about basically. Aldosterone, or not aldosterone, antidiuretic hormone, right? ADH, vasopressin, right? And then aldosterone to a lesser extent, right? To a certain extent. Regulation of GFR through the renin-angiotensin-aldosterone system, which will either increase or decrease the amount of blood volume by increasing or decreasing our glomerular filtration rate, right? Regulation of blood pressure, essentially through the RAS, right? Essentially through the RAS. Angiotensin II, which we're going to talk about a lot, is the most significant vasoconstrictor, systemic vasoconstrictor. The other thing is, it's not on this slide, it actually can help regulate blood pressure and blood volume through another hormone that it makes. Does anybody know what that is? Making of physical red blood cells? EPO, erythropoietin, right? So yeah, that is a minor issue, a minor contributor to blood pressure, blood volume, but it's not insignificant, especially depending on where the patient is altitude-wise, right? Or if they're a smoker, if they're somebody who has kidney failure, they're not making enough erythropoietin, then they don't have enough blood cells, blood volume, all right? Blood osmolarity, what is the osmolarity? Generically?
Movement of water.
Stuff that's in it, right? The amount of stuff that's dissolved in the blood, exactly. Maintenance of that osmolarity is one of the main drivers of solute reabsorption or filtration, right? It's either if we have too much stuff, we're going to put more stuff in the urine to thin out the blood. If we don't have enough stuff, we're going to keep more stuff. Very generic, but that's the basic principle of it, right? All right. Ionic composition, what does that mean? That means regulation of solutes. Okay? Now, it is imperative for you guys to start, if you don't understand, when I start to throw out terms like hyperkalemia, hypernatremia, hyponatremia, hypocalcemia, if you don't get those, ask me what they mean, all right? Because I am assuming that you know what those terms mean, all right? Natremia having to do with sodium, calcemia having to do with calcium, kalemia having to do with potassium, right? So on and so forth, right? Difference between osmolarity and osmolality, does anybody know that one? It doesn't matter, so don't worry about it. If you see them, they're basically interchangeable. It is different. They are, in fact, quite different. One has to do with the amount of solute dissolved in a pound of substrate. One has to do with the amount of solvent or solute dissolved in a liter of solvent, right? Which one is more practical and applicable?
Later.
Right? You don't think about how much sugar you're going to put into a pound of coffee. You put how much sugar you're going to put into a cup of coffee, right? So osmolality is the weird one. Osmolarity is the one that we use more commonly. In humans, there's like a 0.1% difference. So the reason I'm even talking about this, because it's not in the slide, is if you see them, clinically they're interchangeable. So it's not a fine point. It's not something I'm trying to catch you on. Does that make sense, everybody? All right. Blood pH, we talked about that. We talked about how is one of the ways we already talked about the kidneys regulating blood pH? Secretion of hydrogen ions, that's right, right? And so we'll talk about it. It's much more intricate than that, of course. We're going to talk about basics of it, no pun intended, basics of it. But, renal ammoniogenesis, the creation of ammonia so that it can excrete an extra proton. Excretion of protons itself with the aldosterone pathway. Keeping bicarbonate, so on and so forth. Very intricate pathway, a lot of, if you've ever talked about acidosis and alkalosis before, there's pulmonary, right? And then there's metabolic, right? So respiratory acidosis and alkalosis, metabolic acidosis and alkalosis. Metabolic really has to do with the kidney pathway, all right? Calcitriol, we talked about that one already, right? Remember I said don't confuse that with calcitonin, right? Calcitriol is just a vitamin D. Erythropoietin we talked about, and renin. And then regulation of glucose levels, that's really not irrespective of regulation of ionic composition, but it really does have a lot to do. Renal gluconeogenesis is minimal. Really the big player when it comes to gluconeogenesis is what organ?
Pancreas.
The liver, that's right. Most of our glycogen is stored in our liver, not in our kidneys. It does have a small role to play. It just is listed because it is a function of the kidneys, okay? And then ultimately, the kidneys make urine, right? I think it's funny that we listed here under drugs, not prescriptions, but amphetamines, opioids, nicotine, alcohol, right? So, yeah, it also gets rid of prescription medications, right? So not just drugs. But we're going to talk at the end about urinalysis, basics of, urinary parameters of urinalysis, glomerular filtration rate, creatinine clearance, stuff like that, so you should get a prelude of how we measure kidney function, basically, all right? Deamination, what is that? That's right, removal of nitrogen, right? So we're making nitrogenous waste products, right? Anybody in here ever have familiar with the term BUN or creatinine as blood markers of kidney function? Blood, urea, nitrogen, BUN. Creatinine, nitrogenous waste product from protein breakdown, right? Really how we monitor the kidneys clinically, day to day. If you were to go in and see how my kidneys doing, you get a urinalysis and you get a BMP. It gives us our BUN and creatinine. It tells us how efficiently is the kidney excreting these waste products, or are they building up in the system, meaning that the kidney is not getting rid of them efficiently. So more on that later. Okay, renal anatomy, easy stuff. Two kidney bean shaped things, right? Retroperitoneal, what does that mean? Behind the peritoneum, that's right. What is the peritoneum? We haven't talked about that yet. Belly, right? Peritoneal space, retroperitoneal. They're in the back, all right? Just put them that way for right now. That's good. Bean shape is in the middle, right? We all know where the kidneys are? Okay, good. All right. Why is the right one lower? What's right here? Liver. Yeah. So just slightly lower, okay? Now you see this, when you start to check to see if maybe a patient might have kidney stone or they might have a pyelonephritis, which is an infection of the kidney itself, you tap the patient back here at this angle right here. This is called the costovertebral angle, right? So the angle that the rib and the vertebrae makes, tap them right back there at the bottom. If they jump off the table, something's going on with their kidney most likely, okay?
You tap at the point of it or along that line?
No, you just punch them right there in the back of the kidney. So like if I was going to do it, you mind? I'm going to punch this guy real fast. Just pop him right there, you know? And trust me, if their kidney's infected or if they got a stone, they'll let you know. All right? Okay, there's another picture of the kidney in a sort of a CT view, right? Looking from the bottom up. And anybody ever heard of horseshoe kidney? Okay, there's such a thing as horseshoe kidney. You know why they call it that? because it looks like a horseshoe, and it's a kidney. So, good thing about horseshoe kidney is it's usually discovered incidentally. What does incidentally mean? Accidentally, but it sounds more educated to say incidentally, doesn't it? Right? We can. Oh, I found this accidentally. No, found it incidentally. Oh, thank you, doctor. You know what I mean? So, the fusion of this is typically here at the bottom pole, and that's why they usually call it a horseshoe kidney because it looks like a horseshoe. Technically, this fusion can be anywhere up to including essentially what would be like one single kidney, or it can be fused at the top looking like an upside down horseshoe. Don't get bad luck. But truthfully, not so much, because they have essentially two functional renal parenchymas, right? It works just fine. Nothing, it doesn't need to be, surgically separated or anything like that. This patient will live just fine with that kidney, and if they hadn't gotten whatever study they had gotten, like looking at their abdomen for something else, might not have ever even known they had it, because they'll have normal renal function. They don't even really need to be monitored, right? Unless they start to decline into kidney disease, and then it becomes more of an issue, but most of the time these patients have an absolutely normal life, normal kidney health. So just a little gee whiz for you. Okay. Outside of the kidney, all right, this is like the capsule of the kidney, if you want to call it that, right? The renal fat, there's fascia on the very far outside, okay, surrounding it, renal fascia kind of protecting it in this sort of capsule. Then you have the adipose capsule. What's adipose tissue? Fat. You have a fat pad, basically protecting, again, keeping it like a cushion or like a shock absorber, right? And then you have the renal capsule on the inside. This is like, that's the covering of the kidney itself, all right? So the fascia is outside, fat in the middle, and then the covering of the kidney itself, and then next we'll talk about the actual inside of the kidney, okay? But let me show you. Biggest thing with this renal capsule is it is continuous with the ureters, okay? Remember we talked about sort of the endothelium and the inside layer of the heart, right? The endocardium being contiguous with another similar structure here, okay? And so we have this outside fascia here, and then we have this fat pad, right, that kind of serves like a shock absorber, protector, and then the actual layer on top of the kidney, the renal capsule on the outside of the physical kidney organ. Does that make sense? So basically, it's got a 3-layer of protection, and then we get into the actual kidney. And you guys know what parenchyma means? Have you heard that word before? No? Maybe? Okay, parenchyma, P-A-R-E-N-C-H-Y-M-A. It means the functional tissue of an organ. Parenchyma. Okay? If you listen to a surgeon, they'll say parenchyma. You know why? Because they're dicks. Anyway. Yes?
Does the renal capsule also encapsulate the adrenal medulla, or just the...
The renal capsule itself? No. The adrenal gland has its own capsule, right? It's not contiguous necessarily with the capsule on the kidney. It does have a little fat separation, but so it's got its own capsule though, right? The medulla being the inside part. Does that make sense? Yes, okay. And then, like I said, remember the other alternative name, because everything has to have one, is the suprarenal gland. So again, adrenal gland, suprarenal gland, obviously the same thing. Okay? And I referred to this terminology, the poles of the kidney, just north and south, right, top and bottom. But if you see that, that's what we're talking about. Okay, now in the kidney itself. Now does that make sense? We went to the outside, fascia, fat, capsule, now the inside of the kidney itself. Okay? Cortex, just like, very good, perfect time to bring up the adrenal gland, just like cortex on the outside, medulla on the inside. Just like in the, for some reason, it seems like cortex should be the core, should be the middle, but it's not. I don't know. Anatomy, right? Anyway, cortex, the outside portion. Contains all the glomeruli, okay? What is a glomerulus? We'll get there. Give me a minute. All the glomeruli and convoluted tubules, okay? Medulla loops of Henle, okay? And we are going to outline exactly what these portions of the nephron look like, and the collecting ducts, all right? Within the renal medulla, we have a pyramid, and it's going to make more sense as soon as I flip to the next one, and a papilla, which is essentially the tip of the pyramid, okay? So, here we go. Cortex is this outside portion, this right here. The medulla is this darker red portion. The pyramid is this pyramid-shaped thing. And the papilla is this right here, the tip of it, right? If you want to think about it this way, and essentially this is accurate. If you want to think about it, urine, which way is urine flowing? Down through those pyramids that are pointed down into the papilla, into the collecting system, all right? Sort of urinary flow. In fact, a lot of times where you will find lithiasis collection, stone collection, is right here at the renal papilla. So you will see stones kind of forming there. Sort of like, you know what a stalactite is? You know, just kind of dripping down, right? So imagine just those solutes collecting over time. Sometimes they come out of solution and they just sort of coagulate there, if you will. Collect there, and then sometimes a stone forms, okay? Going back, what else was on there? Papilla. So did everybody get those? We're going to go through the rest of this stuff. Is that easy enough so far? Okay. Renal columns, space between the pyramids, okay? Still the medulla, space between the pyramids. Or excuse me, portion of the cortex, I'm sorry. Said that wrong. So columns are these guys right here, this middle portion. Okay? A lobe is a functional unit, okay, and I'll show you exactly why it's a functional unit. It is 2 half columns with the renal pyramid on the inside, and the reason why that's the functional unit is because essentially all of those nephrons and collecting ducts spit out their urine at that one renal papilla and that one calyx, okay? So I'll show you on the picture if that doesn't make sense on the words here. And then you have a minor calyx and a major calyx, okay? And essentially, minor and major calyx just going from the area right in front of the renal papilla, to the larger sort of in the pelvis of the kidney as the collecting system gets larger, going out to the ureter. So let me show you that. Can you guys see? Can you guys appreciate this yellow line here at all? So so basically like half of a column on both sides of a pyramid. Now that's a renal lobe. And again, like I said, the reason why it's a functional unit is because all of those nephrons essentially are feeding into that minor calyx right there. Does that make sense? So all of the urinary products are coming down through here into this area, right? And then this side into this one. Does that make sense? That's why it's a functional unit of the kidney. You guys want to? I'll be over here. Hold on one second. So all of this sort of tissue, this functional tissue, which is nephron mass, essentially, is all feeding into here, which is why this, seemingly arbitrary suction of the kidney is a functional unit. Okay. All right, and then let's see. The minor calyx, see, it's just the small portion right under each papilla. And then the major calyx is just the larger sort of collection, right? So small area to a larger area, okay? Make sense? Too fast? Are we good? All right. Renal pelvis. The major calyces, essentially the renal pelvis is like this last portion of the kidney where all the urine collects before it enters the ureter. All right? Renal sinuses, even though every picture that you see of a kidney is sort of just like three-dimensional, or like this two-dimensional cross-section, right? It's not really that way. It's a three-dimensional space in that pelvis. So in that pelvis, there's more adipose tissue, right? So it is, the renal sinus is sort of the 3D area there where they have more fat, adipose tissue, blood supply, stuff like that. And I'll show you a picture of it because it's sort of hard to, I think, conceptualize. And then the hilum is just the area right where the ureter starts, essentially. So this is the hilum. Okay. This is the pelvis, right? Just the collecting area where all the major calyxes feed into. And you see how, I'm going to go to the next one for the renal sinus. You see sort of how like there's space back here, right? This is a three-dimensional thing, even though it looks like a two-dimensional rendering. So when you see this there's space back here, that's the renal sinus. And this is sort of gives you a better, I know you don't have this picture, but it sort of gives you a better idea that it is a three-dimensional organ. So the renal, it's not, this space, all this fat pad in here, the fact that these papilla are three-dimensional, not just a 2D cross-section, because it looks like you just cut it in half and there's nothing, it's just a completely solid organ. There is a space in that pelvis area. Does that make sense? Everybody? Okay. Any questions so far? Like I said, a lot of anatomy, just eat, and it's, the kidney this portion of it is kind of straightforward, I think. It's sort of named for what it kind of looks like. You know what I mean, and what it does. Okay?
I got a question for you.
Sure.
The minor calyx, is there one per pyramid?
Mm-hmm. Essentially, yeah. It's what the papilla sort of drains into. Right. Yep.
So like it's variable then how many pyramids are in an individual
In a kidney?
person's
Yeah.
kidney?
Yeah. It's not. That's not. Yes. Like
It's like a big number.
there's
It's
not
like
always that fixed number of it.
It's
No.
like 8 to 18 minor calyxes. That's a pretty big discrepancy.
Uh-huh. Just depends on the size of the person. Yeah. And then let's see the nephron. Any other questions? Sorry. Any other questions? So now we're going to talk about the nephron. All right. The renal corpuscle is the glomerulus and the Bowman's capsule. All right. So if we say the renal corpuscle, glomerulus, and Bowman's capsule. And does anybody remember where we said all the renal corpuscles are? What portion of the kidney? The cortex. The corpuscle is in the cortex. The renal tubules, now that's different. The loop of Henle's go down into the renal medulla. The convoluted tubules are generally in the cortex, all right? And the collecting ducts go down into the medulla as well. So what does that mean? So the corpuscle and the convoluted tubules, right, which is conveniently both start with a C, are in the cortex. And when we get to a better picture, I'm going to show you, I'm going to outline this a little better. And then the loop of Henle are in the renal medulla. Okay? This is a critical concept, you guys. The collecting ducts are not technically part of the nephron. They do function to reabsorb some water, but essentially urine is essentially made by the time they get there. All right, and that will make more sense later. Just understand for now that the collecting duct, which is the end part, is not technically a part of the nephron. All right? So, if you look here, I'm going to go to this next one first. I'll come back. Don't get me wrong. So, here is the Bowman's capsule on the outside of the glomerulus. And what is the glomerulus? Anybody remember? Just a ball of capillaries in the inside of the Bowman's capsule. Okay? So you have an afferent approaches, and an efferent arteriole going in, and the middle section is literally just a ball of capillaries. All right? Now there's some other structures on there that we're going to talk about. But then after the filtrate exits Bowman's capsule, it goes into the proximal convoluted tubule. So when we say proximal and distal convoluted tubule, it means in relation to Bowman's capsule, in relation to the glomerulus, okay? And everybody knows proximal and distal, I assume, by this point? Yes. All right. So the proximal convoluted tubule is closer, and the distal convoluted tubule is farther away. All right? In between the two convoluted tubules is the loop of Henle. So named because it is a loop. Okay? So the proximal convoluted tubule comes down through the loop of Henle goes back up through the distal tubule, and then out the collecting duct. Now, I urge you, when you're looking at pictures, to make sure that put your pen on screen and trace it, because they will draw these nephrons inverted sometimes, or upside down, or sideways. So if you don't, what'll look like the proximal tubule will actually be the distal tubule, just based on the picture. Does everybody understand what I mean? So just put your pen on the glomerulus and trace it, like, oh, okay, that's pointing to the distal tubule. That's pointing to the proximal tubule. Just do yourself that favor, all right? And so looking at this, back to the other one, right? So we have here this section of the, right here, this is the glomerulus, and this, of course, represents the cortex. And then we go out, the proximal and distal tubules here in the cortex, and this loop of Henle dives down into the renal medulla, okay? And that's what I was talking about, this rendering right here, sort of all of these, which is a lobe, feed into this one part, and essentially that's what's happening. Urine is coming out this way. You guys following? Okay, good? Okay. All right, and we're going to talk about the rest of these structures in just a little bit. Any questions up to now? Making sense so far? We got the Bowman's capsule, the glomerulus, right? Proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct, okay? We're going to talk about filtrate and urine as it travels through that later on. So for right now, we're just talking about structure, okay? Cortical nephrons, most of our nephrons, and these are shorter loops of Henle, right? When I say that, it's not called the short loop of Henle. It's just a short loop of Henle. So it doesn't physically extend that far into the renal medulla, okay? What does the prefix juxta mean? Next to, right? Or close to. So juxtamedullary nephrons are closer to the medulla, and they dive farther down into the renal medulla. Okay, longer loops of nephron. Long loops of Henle. And then other difference. We haven't even defined it yet, but what do you think paratubular capillary means? Capillaries around the tubule, literally, right? And this is how these paratubular capillary networks are how we make urine and reabsorb water and solutes, okay? This is how we do excretion and reabsorption, okay? Paratubular capillaries only in that cortical nephron. So they have a short loop of Henle, and they have paratubular capillaries, okay? The juxtamedullary have longer loops of Henle, and they have a structure called the vasa recta. You want to know what the vasa recta really is? It's just an extension of the paratubular capillaries because they have a longer loop of Henle. Okay? So, if you look at this rendering here, this is a juxtamedullary nephron, and its loop of Henle is longer. This is a cortical nephron, and its loop of Henle is shorter. And do not get it misunderstood. Both nephrons, where is their renal corpuscle? Where is their Bowman's capsule and glomerulus? In the cortex. Both, okay? Both. Cortex has the corpuscle, right? So just because it's called a cortical nephron doesn't mean its glomerulus is somewhere else. Does that make sense? The only thing that makes a juxtamedullary nephron different is the vasa recta and the longer loop of Henle. Okay? Anatomically, their Bowman's capsule and their glomerulus are in the same space. And that's important for you all to not get that confused just based on the nomenclature. So the cortical nephrons, shorter loops of Henle. Okay? Renal corpuscles on the outside. That turn in the loop of Henle, you'll hear it referred to as the hairpin turn. Looks like a hairpin. Okay. And paratubular capillaries that arise from the efferent arteriole. Okay. So just to go back just for the rendering so you can see it, that spider web of vessels surrounding the tubules, that's the paratubular capillaries, okay? For visual representation. Juxtamedullary nephrons, corpuscle still in the same place, right? Cortex. Descending, loop of Henle dives deeper down into the medulla. Okay? Paratubular capillaries and vasa recta. Good. New breather. Take a lap. No breaks.
Is there a point of delineation of when it changes to the vasa recta?
Not an anatom. No. Not the short answer is no. Yeah. What's the vasa recta? It just helps to continue to make. It helps to continue the secretion and tubular secretion, tubular reabsorption in the longer loops. Okay. And that's exactly what this filtration and reabsorption, secretion and reabsorption. So if you look, basically here is a cortical nephron with a shorter loop of Henle, just the paratubular capillaries, right? And essentially, the paratubular capillaries around the distal and proximal convoluted tubules, the vasa recta going around that much longer loop of Henle, right? It's harder to maintain that osmotic gradient without any kind of blood flow in or out or urea recycling, which we'll get to if you have to go down this deeper dive here. And then there's other things to it. The vasa recta is also a very oxygen-deprived environment, so reabsorption of hydrogen and bicarbonate is different there. So it's just an additional anatomic structure to continue to facilitate blood flow, tubular secretion, and reabsorption, and just that longer piece of nephron. Yeah.
Sure. So on the cortical nephrons, the capillaries really aren't going down in the loop.
Not much. It's not as delineated as it shows here. Just this is sort of illustration. So they do have some in the loops of Henle in like the upper portion, but it doesn't really dive down as far. There is blood flow down there. Don't get me wrong, but the paratubular capillaries are literally just kind of more around the distal and proximal convoluted tubule. Yeah. Yes, sir.
Answer your question.
Okay. Okay. Renal blood supply. We're going to talk about two different flows, renal blood flow and glomerular filtration rate. So blood flow through the glomerulus, blood flow to the kidney itself. Right now, we're focusing on blood coming in and going all the way out. So the whole loop, the whole circuit, right? So unfortunately, it starts to sound similar, so we'll take this slow. But renal artery, easy, right? Coming into the renal artery. Then it drops to the segmental artery. So we're going this direction, by the way, with blood flow. Okay. Enter lobar, arcuate, enter lobular. So don't get those confused. And then we get into the actual glomerulus, the afferent arterial. Remember, afferent approaches the glomerulus. Afferent approaches something. Afferent arterial in the glomerulus. Okay. Efferent arterial, paratubular capillaries, and then we kind of go the opposite way with our veins. Lobular, arcuate, lobar, segmental, and then the renal vein. And I know that's fast. There's really no way to do this other than to memorize this. Okay. I wish I had a good trick for you. If you guys come up with a good acronym, go for it. I spend more time trying to remember what the acronym means than just remember the things. Okay. So, yes.
So are there like multiple of these nephrons in the pyramids?
Yes, sir. There's millions of them.
Okay.
Mm-hmm. I mean, it's the function. So, like you withstand a loss of nephron mass, and you still have kidney function. So, yeah, there's it's not just one in it's millions. Yes, sir. Yeah. Yeah.
So the arcu and the interlobular, they both look like they're in the cortex, like in the column in between. I guess that's just where it's pointing, but how do you differentiate the two arteries?
The interlobular, is that what you're talking about?
Yeah, correct. Then the arcu.
So the interlobular goes between the renal lobes, renal lobules. So there's lobes and lobules, but basically the interlobular is smaller.
Small.
The interlobular is the one that's going to be going into the afferent arteriole. So it's the last stop before you go into the artery that brings you to the glomerulus. So,
And with
Yeah.
it, is the arcuate just bridging the gap between functional
yeah, they're
organs?
just, I mean, it's just, we're going from renal artery to smaller, smaller. Basically, this is like this is the journey like we talked about in the circulatory system from artery to arterial. And on that note, what is weird about the glomerulus? Does anybody pick it up? It makes the glomerulus unique as far as blood supply.
It has like a capillary bed in it, but it's still oxygenated.
What'd you say? Yeah, you guys are both get together. Good job. Yeah. Yes, it has an arteriole on both sides, right? It doesn't have a postcapillary venule on the outside of it. It has an afferent and efferent arteriole. So it's a capillary bed that has an arteriole on both sides. Right? It makes it fairly unique, right? Which is to say completely unique, because it's the only one that has it like that. All right? So, and why? Because we still have to do with tubular filtration and reabsorption, right? We have to get everything in and out. Blood supply, numbers. These numbers you don't have to know, okay? It's just a lot, right? And the conceptual idea here is that how fast or how frequently the kidneys filter through our blood volume on a given day. You know what I mean? 1.2 liters per minute, right? This is a significant amount, right? So think about that on any given day. How many minutes there are in a day? How often your blood does recycle? Yes? No. It doesn't. So again, that's what we are going to talk about, differentiate between renal blood flow and glomerular filtration. So yeah, the renal parenchyma still has to be fed through the capillaries, and so that if that's what nutrient exchange that you're talking about, that is feeding the actual kidney itself and the tubules and all that stuff. And then we're going to talk about glomerular filtration rate, which is the production through the glomerulus of urine. So no, it doesn't. The answer is no. It doesn't just happen there. Like a capillary exchange is still happening throughout the organ. Okay, hopefully it'll make more sense when we get to the physiology of renal blood flow. If it doesn't, let me know. But right now, the answer to your question is no. It doesn't just occur there. Okay. So right now is a good segue, sort of, but the blood supply again. We're coming into the afferent arteriole, and we're going out the efferent arteriole, and here the structure in the middle is the glomerulus. This on the outside is the Bowman's capsule, okay? And then in between, the space, the physical, literal space, the cavity between the glomerulus and the Bowman's capsule is called the capsular space. Simple, okay? And the glomerulus, essentially, you guys remember, everybody play with Play-Doh? All right, when you put the Play-Doh in the ball and you squeeze the thing down and the spaghetti comes out, all right? So regulation of glomerular blood flow and glomerular pressure sort of reminds me of that, right? Depending on how much pressure there is to be squeezing stuff out. Sometimes stuff escapes that shouldn't escape, like proteins and blood cells and white blood cells and things like that. Normal pressure situation, those things don't escape. But the point is that in the glomerulus itself, stuff comes out. Nothing goes back in yet. Okay? That's the initial point of urine production, the initial point of filtration. Does that make sense? Sort of? And then blood supply. This is another here. This is it in numerical order. Okay? The one thing to keep a note of is this one. Vasa recta is only a portion of blood flow in the juxtamedullary nephrons because they're the only ones that have a vasa recta. right? Okay. It's like take a pause and see how everybody's doing. Cranial nerves are a lot, aren't they? What's up?
For filtration in the glomerulus, is that a regulated one or is just?
Oh, it's regulated, yeah. We're gonna talk about regulation of the glomerulus, glomerular flow, glomerular filtration rate. Absolutely, yeah. It is, and we're about to get into sort of the filtration mechanism. How do we keep stuff in that we need? How do we get rid of stuff that we want? It's definitely regulated, yes. So, speaking of, segue, here we are. Blood flows in the kidneys, right? What are we doing? We're making urine. What is the main function? The main function of the kidney is to filter blood and to make urine, get rid of all that waste product, right? And so, right? Blood comes out, blood goes in through the afferent arteriole into the glomerular capillaries, and stuff is squeezed out. The stuff that's squeezed out is an initial part called the filtrate. All right, you might see it called the ultrafiltrate. All right, and then as we go down the tubules and so on and so forth, we start to absorb and reabsorb other substances, get rid of waste products, keep nutrients, so on and so forth. And that's what we're about to start getting into here. Filtrate is first, it's not urine yet. That's the important thing. When you're in the Bowman's capsule and that stuff initially squeezes out into that capsular space, that is called filtrate. That is not urine yet. Why? Because it still has a bunch of stuff that we need to reabsorb and keep. All right? It's not a finished product yet. Not till we get into the collecting duct is it really urine. And do you remember me saying the collecting duct is not a part of the nephron? It's not a functional part of the nephron. The nephron is the functional unit. The collecting duct may reabsorb a little bit of water, but mostly it doesn't do much of anything as far as solutes or nutrients, so on and so forth. Okay? Does that make sense to everybody so far? So blood comes in, filtrate squeezes out. By the time it makes it to the end, then it's urine. Okay? Again, an oversimplification, but we're going to go through the steps. Does that make sense so far? Yes. Okay. Efferent blood, squeeze out into the capsular space. The little blue dots are the filtrate, ready to go into the proximal convoluted tubule to begin the journey to become urine. Okay? All right, listen. Take a break. Then come back in 10 minutes, and then we'll finish up. We're almost done. All right? But I feel slipping through my fingers right now. Okay.
No, I sent it last one.
Okay.
I sent it last one. I didn't know this was
They're involved in feeding them. Not really. The stuff moving through fuel cell you're also just kind of like it's sort of nutrient and water and sort of a sort of balance
You just suck it up.
You're over here pretending to be hurting the last
She leave? She left?
You know, I said she was sick. Beginning of school.
Uh-oh.
Sick.
On the indoor here? Uh-oh. Next.
Get my full sleep.
Here, did you see the other one I just posted? It's one of those where after I take it, I'm like, every time I take it, I was just fine. It's like interesting. Yeah.
Actually, no.
You know what?
Yeah. Yeah. Like in the very beginning, there's like it's like question 10. It's like a question, and then the answer is a completely different question step. So like I fixed that. I mean, it's the right. I mean, both are relevant, but like you can look up. Yeah, I don't know. So I changed it to reflect the. And then there's the next one where it's like you're a couple down. The question was wrong. The answer was wrong about the red nuclei. It said something. It said something about like the red nuclei does this, about like emotional response or something like that. But it's motor coordination. Yeah. I crossed out some more. I crossed out some more on the second one, and then there was a couple of them I put like extra credit by. It's like you could decipher the correct answer based off of like the process of elimination, but it wasn't mentioned in the slide deck.
Yeah, I saw that.
Yeah. I always recommend Control F-ing the PowerPoint if it doesn't make sense, because it's probably not in there. That's why. Yeah.
It's just. Which is not like
With one of your boys out of condition, does the other one get punished? He's not allowed to go to the pool.
Does he get punished for what?
Not allowed to go to the pool.
Yeah.
So like receiving no pool time because it'd be too much for the other one to handle.
Yeah.
Dang. That's oof, big oof.
You should see him if one like what did I bring the other day? I found a coin. They're really into coins. And I found one coin and I gave it to either Bo or Boone. And when I gave it to him, the other one was like, "Where's my coin?" Like this. Like if you don't get a bone, like
Yeah, you gotta come with pairs. When you have kids that close, it's
I
like
learned
having
real
twins.
quick. Toys get expensive.
I had a major friend pretty late. I had twins, late 30s or whatever, and every time they were out, every time, doesn't matter what like accessory, what clothing item, like stroller, car seat, everything was matching. So it's like they're both girls. And I was like, that must be insanely expensive.
It's the same toys.
Just killed me.
Gotta get 2 tracks. If one has a shark shirt, the other one has to have a shark shirt.
And dark room. Killed me. I have a boy and a girl. My girl just wants everything frou-frou, ballerina, tutus, new paint, new coloring items. Boy just wants a ball. Just anything spherical.
Yeah.
ready? Well, I'm ready, so let's go. All right. So, review. Put it back together, right? So, parts of the nephron, right? Glomerulus on the inside, Bowman's capsule on the outside. From the capsular space, we go into what? The proximal convoluted tubule, right? And then we go into the loop of Henle, the descending, the hairpin turn, and the ascending loop of Henle. And then what's after that? The distal convoluted tubule, and then into the collecting duct, and then out to the environment, onto the floor. All right, or into the floor, whatever. All right, so yes, very good. Both juxtamedullary nephrons and cortical nephrons have that exact same structure. The only difference is that the juxtamedullary nephrons have what? A vasorecta because of the longer loop of Henle. Okay, very good, very good. Right? Where are all of the renal corpuscles located? Regardless of the type of nephron. In the cortex, right? Where are all the convoluted tubules located? In the cortex, right? Corpuscles, convoluted tubules, cortex. They all start with C. Easy, okay? Then where are the loops of Henle and the collecting ducts? In the medulla, down into the medulla, okay? Very good, very good. And the kidney ultimately is used to make urine. There's the review for the physiology that we've done so far. Any questions so far? All right. Flow through. Afferent approaches, efferent exits. All right. I said that 7,000 times because it's important. I want you guys to know that. It doesn't just have to do with blood flow. It also has to do with neurons, right? Sensory and motor input, right? Efferent, afferent neurons. You guys talked about those? I hope, maybe. A little bit. We'll see. Just say yes. Yes. Make me feel good. All right, here we go. Here are some abbreviations that you might see, okay, just in case you want, just so you see. And also, you're going to see loop of Henle as all caps. You're going to see L lowercase big H. Same thing, obviously. Just in case, I know that sometimes it draws your eyes. It looks different. Is this a different thing? It's not. It's the same thing. All right. All right. So again, unusual because this ball of capillaries we call the glomerulus is bookended by arterioles on both sides, right? So unusual, but again, having to do with tubular secretion reabsorption, with formation of urine, okay? And again, we just went over this as we're coming in, the afferent arteriole into the glomerulus, it pushes stuff out into this capsular space. That is the filtrate. It is not urine yet, because it has to go through the tubules and the loops of Henle, right? Okay. Afferent arteriole is a little bit thicker. It has more to do with constriction and reduction of blood flow into the glomerulus. That sounds stupid to say that because it's the end pipe, but the efferent arteriole has hand in that as well by vasoconstriction or vasodilation. But either the point of what I just tried to say in a very stupid way is that the afferent arteriole has a more of a capability to expand and contract, all right? So it can create a more profound effect of blood flow into the glomerulus than the efferent can. The glomerulus itself, again, is just a ball of capillaries, okay? What we're getting into now is the filtration mechanism, all right? How do we keep the stuff in that we need to keep in? And it's a multi-layer filtration system, okay? On the bottom there it says podocytes. They look like octopus, right? What is a podocyte? What's a pod? P-O-D. Foot. And cyte is a cell. So it's a foot cell. It looks like it has all these foot processes. Like I said, it looks like arms of an octopus sitting on the outside of the glomerular capillary. All right? So this podocyte right here has these foot processes that surround the glomerular capillaries, and movement of those foot processes can either increase or decrease this space right here. So what you're looking at, the easiest way is what you're looking at is the lumen of the glomerular capillary. What kind of capillary is the glomerular capillary? Fenestrated, right? Fenestrated. Now we know why, because it needs to be able to let stuff in and out, or out easier. So inside, we have the fenestrations of the glomerular capillary. We have the capillary basement membrane, which is that blue line, and then we have podocytes sitting on the outside. Okay? So as we move, it moves those foot processes in or out more. It's going to either let larger items out or smaller things, right? So filtrate is going out this way. This yellow space represents Bowman's capsule, the capsular space, right? So we're pushing stuff out of the glomerulus, making the filtrate, right? Does that make sense? Okay.
So, sir,
yeah.
Is it the podocyte itself that's causing the constriction, or is it just
yeah.
the foot process?
It's the podocyte is the cell moving the foot process. Like it doesn't necessarily move; it'll just open or close its foot processes a little bit. We have more coming up. Hold on a second. Efferent arteriole exits, right? And basically, this is delivering the stuff that remained in the glomerulus, right? So the stuff that wasn't filtered out, the proteins, the blood cells, the remaining solute, the stuff, the plasma that's still in the glomerular capillaries that didn't get pushed out, it goes back into circulation, right? Back through. Okay? So, and this is why I told you, this is one of the other things you need to do. Depending on the picture you look at, the afferent arteriole may be on the top, the efferent arteriole may be on the bottom. It may be facing, the glomerulus may be on the bottom, and the efferent arterioles. Just draw yourself, put your pen on the paper or on the screen and figure out exactly which one is which, just so you don't get it screwed up. Because if you just look at this, and every other picture you look at has the afferent arteriole on top, you're going to get it mixed up. Does that make sense? Does it make sense?
Afferent's always going to be the thick one.
Afferent, yeah. But again, you can't rely on that. If you're just looking at an artist rendering or a drawing or something like that, just look and see which one is going into it. You know what I mean? Just do yourself that favor because it can get confusing the way they draw them. They draw them 1,000 different ways. Yes? Yeah. Yep. The one that starts ahead. Yeah. And the reason I say that is because if you're just looking at this, and if I say, what is number 3, right on this picture, what is number 3? And every other picture you've seen in every text has the afferent arteriole on top. You just say afferent arteriole, you're going to get it wrong. And I don't want you to just based on the drawing. Do you know what I mean? Yeah.
Would you ask what is number 3 with the arrows? Or no arrows?
What do you think? Get out of here. That's smart, yeah. I'll leave it there for you. So anyway, we're going to afferent arteriole, glomerular capillary. See these podocytes, right? And then we have the filtrate, and then what remains that didn't get pushed out into the filtrate comes back out through the efferent arteriole. Okay? Talk more about the filtration. These are also terms that you have to get straight in your head. Tubular reabsorption and tubular secretion. Okay? Reabsorption means we're pulling stuff back into the blood. Secretion means we're pushing it into the tubules. Okay? So think of tubular secretion as pushing stuff into tubules to make urine. All right? Reabsorption means we're reabsorbing stuff back into your blood because it's usable, like water or glucose or whatever. Okay? It's just imperative that you get those two straight. Because if you have those mixed up, you're going to get everything else wrong. All right? Why do they call glomerular filtration and then tubular reabsorption and secretion? I don't know. You're going to have to ask somebody else. That's just what it's called. Okay? So in the glomerulus, we're filtering everything out. And then as we go through the tubules, if we're reabsorbing something, that means we're taking it out of the filtrate and putting it back in because we need to keep it. If we're secreting it, it means we don't need it. We're putting it into the tubules where the urine is to ultimately excrete it. Is that clear? Because that is critical. If you get those flipped around, you're going to get screwed up on the entire exam. Okay? And here you go. Just so you know. It's terminal. Have it laid out for you because it is important. All right? All right. More of the filtration mechanism. Okay? Glomerular filtration rate, we're going to talk about, essentially is exactly what it sounds like. How efficiently is the glomerulus filtering and making filtrate? All right? And that has to do with a whole host of factors that we're going to get into in the next couple days. All right? For now, GFR. Okay? But if you can see, this is the interaction that we were talking about with the peritubular capillaries in the base recta and the reclamation of water even in the collecting duct, is that we make 100 almost 200 liters a day of filtrate. Like, it's over every minute, 1.2 liters of our blood is passing through, right? We make a ton, but what we ultimately do, if we're well hydrated, is make about 2 liters of urine a day, which is about where you should be, okay? Multiple, whole host of reasons why we can make more or less. Suffice it to say, most of what goes into our kidneys stays in the body. Most. Excuse me. Okay. Filtration mechanism, right? It's a leaky capillary. It is a fenestrated capillary. Remember that, right? Just the little holes in there that let stuff out. The fenestrations let out plasma, small proteins, but they keep in blood cells. Larger proteins like albumin, the things that we need to keep in the system. All right? I'm sorry. So, through the fenestrations, through the foot processes, and out into the capsular space. Okay? Now, here's a new thing for you. Mesangial cells. We'll talk about them more. I have a better picture of them later. But essentially, so think of the as a 3D ball of capillaries, right? That's the glomerulus. Inside sort of that network of the capillaries themselves are these cells called mesangial cells. Okay? Technically, they're called intraglomerular mesangial cells because they're inside the glomerulus. They have properties like smooth muscle, and so they can expand and contract. So they add to the maintenance of the glomerular filtration rate. All right? We'll get more to that later. I have a whole slide on them. I just wanted to highlight why somebody was going to ask me what does this red circle mean, so that's what that means right now. Okay. So we have from inside to out, we have the fenestrations in the capillary. The basement membrane is a secondary layer of filtration. And then we have the slit membrane, which is the space between the octopus's legs. The podocyte foot process. Okay? Don't worry about this. Don't worry about numbers like this. Okay? Don't worry about numbers like this. Just understand that as it goes out, it gets finer essentially so that we can keep more stuff in. All right? We don't want albumin. We don't want red blood cells. We don't want large sugar molecules in most cases, right? We want to keep that in. So that's the whole purpose of this initial tranche of filtration. Okay, yes?
So is this going from superficial to, or deep to superficial, or superficial to deep?
Inside to out.
Inside down.
Here's a good picture of it. So we're going sort of in this direction, if you will, right? I know that's a bad because it's not 3D, but you get what I'm saying. From where the blood is to the capsular space. Okay? So we have the fenestrations, we have the basement membrane, then we have the slit membrane between the podocyte foot processes. Okay? And all these are, what this is doing is regulating what is allowed to escape into the filtrate. It's a complicated mechanism with a simple function. Does that make sense to everybody? Right? It's keeping in the stuff that we need to keep in. If we didn't have this, then albumin would be being lost. Glucose would be being lost, right? So when you have disorders of this filtration mechanism, which you'll learn when you get to senior semester in nephrology, it's thrown off. And so you get significant albuminuria, albumin being lost in the urine because it's making its way into the filtrate. Glycosuria, because of diabetic nephropathy, for one, right? So we're losing a lot of our glucose in there, and so on and so forth, okay? Now here's the intraglomerular mesangial cells. These little sort of green guys with the blue center. So they're just cells. Again, like I said, if you conceptualize like a ball of capillaries, there's space in the middle of it, right? There's space in between the ball, right, as the loops go around. In that space are these mesangial cells. And they have properties like smooth muscle. So what they can do, or what they do, what they do is when they expand, right? The technical term is contraction, right? Contraction of a smooth muscle. But when they contract, they wrap around sort of the capillary and they squeeze down the size of it. Does that make sense? So when the smooth muscle things contract, they sort of like push out, right? This represents the capillary with the blood cell in it. The purple thing is the mesangial cell. When they squeeze and they push out, they squeeze and make the lumen of these capillaries smaller. Does that make sense, everybody? Right? And again, what does that do? That regulates glomerular filtration rate. It slows it down. Right? If the lumen of the capillaries is smaller, the amount of blood rushing through it goes down. So GFR, glomerular filtration rate, goes down. When they relax, they open the capillaries back up and the glomerular filtration rate goes back up. Does that make sense? Yeah? Okay. It is a minor mechanism of GFR regulation, very minor, because they're not necessarily large enough to have a huge effect on the capillary lumen, but it does add to the GFR regulation, all right? And so, when relaxed, surface area is maximal, meaning the capillary is what open when contracted. They slow down the GFR. Okay? Anybody, you know those, like, what do they call them? Like a strap wrench that you use to get like oil filters off, right? You know? Go around, reduce the surface area. All right, you guys. That's it. That's anatomy. Easy day. What? This is the easy day for renal physiology. Yes. Yes, ma'am.
I was just gonna ask, is that self-contracting the function of the ADH?
Say that again, I'm sorry.
Is that self-contracting and relaxing the mechanism of the ADH?
Not. So, yeah, sort of. It's more it really has more to do with angiotensin. It has to do with the RAS system when we're trying to slow down GFR to preserve intravascular volume. ADH really has more of its effect on the tubules where we're actually going to open up channels to just reabsorb water. So the mesangial cell, it's related, but no, it's not because of that. Yeah. Okay. Any other questions for me? I have a question for you. Vasa recta. Correct. Me too. Look, man, stupid memory tricks are sometimes the easiest way to remember shit, all right? It all starts with the letter C. Take it or leave it if you want, but I think it makes it easier. So that's all that I have for today. I think that's enough. Tomorrow we are going to discuss we're going to get into the glomerular filtration, and then after the exam, when you're listening again, we're going to start talking about like tubular secretion or reabsorption on Friday. So anyway, see you guys later.
Order.